Without further ado, I'm about to introduce Dr. Ronald Carter. Thank you very much.
Thank you. I have a lot of details in this presentation, and there's no way that we can go through the details for some of it. It's the primary reason I include it is to try and convince you of the amount of effort and the research that's gone into this. What we're going to present here is based on studies of thousands and thousands of people with AMD, and a lot of work went into working out these genetic rearrangements. So what I would like to talk to you about are the causes of AMD, and you will find out a little bit more about that. And then the next question is how to best identify people who are at risk for developing the disease before it happens. And then the third part that's emerging is how to use genetic testing to refine treatments and have better outcomes. And I want to explain a little bit about that. So the first part you already know. This is a disease that shows up when you are older. It is rare to get this disease when you are less than 50, and most people develop the disease after the age of 75 to 80. You already know that. The second thing is it's actually a very common disease, and about 10 to 15% of people, by the time they reach 85, will have lesions of AMD. And since I consider this a genetic disease, this makes this actually one of the most common genetic diseases out there. So when you're trying to manage this as an optometrist, an ophthalmologist, your physician, you as a person who might be affected, you have three goals. You want to find out who's at risk of vision loss. You want to educate them about how they can prevent that loss if possible. And you want to manage that loss of vision as best as possible so that there is better outcome in terms of vision. Those are your three goals. In looking back at families with AMD, one of the first things that was realized was it was a mixture of things that you were born with, your family history, the genetics of your family, as well as what you did to insult your DNA for the rest of your life. You get your package of DNA from your parents, and then it acquires errors and mistakes and mutations during the course of your life as a result of exposures to toxins and the way you live and just random chance. Most of those errors are random chance, but you can make them more likely if you treat your DNA badly. And I know now that you folks have just been told how to eat. I can tell you I had a 12-grain bagel this morning, which is, I think, good, right? But then I washed it down with a donut and Coke Zero, which is probably bad. But I had an apple last night, so it all evens out, right? What have you got here? The fact that as you get older, you accumulate more mutations, you're more at risk. That you have family history is a big part, and I'm going to tell you about that. If you smoke, or you used to smoke, that's a risk factor. If you're Caucasian, that's a risk factor. And if you are overweight, you're a risk factor. And actually, it's a little bit worse if you're female as opposed to male. And what do you notice about all of these things? Some of it's your lifestyle, right? And they're really common things. And when you actually look at it more specifically, there's one that's exposure to sunlight, which is damage, radiation damage to your retina. But these things, they're looking a lot like heart disease, right? Cardiovascular disease, high blood cholesterol, diets that are high in fat or meat, high blood pressure. This is a cardiovascular problem. It's affecting the vessels in your eye. This is a cardiovascular disease that comes to your attention because it affects the blood vessels in your eye. So, in summary, the end of this talk is here. Your risk of developing this disease is primarily related to your genetic predisposition, what your parents handed you, and unfortunately you can't go back and blame them because they're long gone, but it would have been nice when your mama was telling you not to run around with a stick because you were going to put your eye out. You could have said, well, yeah, well, I'm going to go blind later anyway, and it's your fault. But this is the big one, genetic predisposition. And then there's other things like smoking, your diet, whether you gain weight, and whether you work outside and don't wear sunglasses, and some other things. Why is that? It turns out that this is a disease primarily related to two types of metabolic functions. The first one is that you have a system of proteins in your blood called complement that are meant to repair and to protect you from external infections, bacteria, developed a whole long time ago. But when that complement system doesn't work properly, you have vascular disease, and I'm going to explain that in a minute. The other thing that's very important is reactive molecules that have a high energy content, oxidative metabolism, and your retinal cells require a high energy level to do their job, and it's related to their ability to metabolize oxygen and to deal with compounds that are reactive. And if you can't do that very well, if you can't maintain an energy level for those retinal cells, or if you don't handle those reactive compounds very well, then you have a problem with the blood vessels in your eye. So the first part is this complement protein, and basically this is a system of defense that you inherited from animals that developed it 500 million years ago. Your system is essentially the same as this animal's system, the horseshoe crab, which hasn't changed in 450 million years. And it's the exact same kind of proteins. And it's a complex of proteins that are meant to attack bacteria and form a ring and punch a hole in the cells of the bacteria, and the bacteria is supposed to bleed to death, lose their insides. And what happens is when this system, which is running around in your blood, is looking for things to do, if it finds things to do in your retinal cell layer where the blood vessels are, and it starts poking holes in the wall of your blood vessel, then you get leakage of things out of your blood vessel into your retina. So how did this become a problem? Because of the genes associated with controlling that reaction of that complement protein. The other thing, as I mentioned, was the way you handle energy metabolism and reactive compounds in your retinal cells. And there's a whole series of genes, one in particular called ARMS2, that make proteins that have an impact on that. And in general, the system is very simple. Your genes, the things you inherited from your parents, code for the way you make proteins. The proteins have the functions that determine how your tissues work. If you have a problem with the gene, then you have a problem with the protein, then you have a problem with the way the tissues work. So, in practical terms, this was recognized some time ago, that you could make some of the symptoms better if you did a couple things. And one of the standards of care for dry AMD is to try and alter the diet. This is to deal with components of the reactive molecules in food and to help you fight the protein deficiencies. The other component was to try and interfere with that vascular response in the retina when the complement damages it. And that's the basis behind these vascular endothelial growth factor injections, where they're inhibiting that type of formation of blood vessels, and that helps with the retinal lesions in the eye. So those types of treatments are based on what we now know as protein pathways that have a problem, and they're trying to deal with it. Where genetics comes in is you can be much more specific about how you apply this kind of thing once you identify the exact causes of the protein problems. And where they started with this was that they knew that if they took a group of AMD patients and they all gave them the same treatment, some patients did better than others. The same treatment applied to people with similar lesions had slightly different effects from one person to the next. It wouldn't work very well on this person, it would work better in that person. Okay, so why? Only 25% of patients will actually do better with a standardized approach to treatment across all of the people. What do you do about the 75% who don't respond very well? You figure out why they're not responding very well, and you alter your treatment to try and benefit them more. Because this is a disease that's 80 to 90% genetic predisposition, that brings you back to genetics. That's the number one thing, what your parents handed you. You can't pick your parents. And as I said, the mechanism is you have a problem with the DNA sequence for the genes. It causes a problem making the proteins. The problem with the protein causes the tissue to not function properly. So you have to correct this protein deficiency or antagonize it so it doesn't mean anything. And here's the proof that it's actually a genetic predisposition. If you take the general population risk, the chance of getting AMD across years of life, by age 80, about 9 to 10% of people will have AMD in the general population. But if you look at the relatives of people, the father, the daughter, mother, son, the first-degree relatives of somebody who already has AMD, those first-degree relatives are at almost 50% risk. It's not quite 50% because it's not absolutely genetic. But this indicates that there's something in the genetics of that family that makes you very likely to develop it. So how do you go about teasing this out? And the approach was to take thousands of patients with AMD, look randomly for genetic markers, sample the genome across thousands of different parts of it, looking for an association. You have this little change in the DNA results in this kind of an outcome with AMD. Do it for thousands of markers, and then you run statistics like the government does, and you try and pull out little associations. You're more likely to have a problem if you had this marker, less likely to have a problem if you have that marker. And then you start all over again with another population of people, and you test that and see if it predicts for what happens in them. And if it predicts for what happens to them, then you have a real association. Then you start to have a cause and effect, and you know the problem. Why do you want to do this? Because you want to be able to predict who's going to develop the problem, and you want to titrate your treatment, make it better, tailor your treatment to the specific genetic issue. How does this work? I'm sure you've all seen pictures of DNA. Basically, it's a code book of instruction. It's actually made up of 6 billion codes. Every cell you have has 6 billion parts to the code. So there were a lot of parts that they had to look at. And some diseases comes down to one error in one part, one of those 6 billion base pairs, we call them. You can have an error in 1 out of 6 billion and die from it. That's not the case with AMD, but it has some effect. And cumulatively, it's actually not very many base pairs that have to be affected before you have a problem. And it's simply a change in the code where there's supposed to be a molecule of a certain kind. When you're copying your DNA, you put in the wrong one. Instead of putting in an A letter, like this type of molecule, you put in a T or a C or a G. There's only 4. And the way you make your DNA and copy it and hand it on to the next cell makes a mistake. And most of these errors over time accumulate randomly. So you have them. You have them all through your genome. Every time you make a new cell, you make some mistakes. Most of them don't mean anything, otherwise we wouldn't make it this far. But over time in families, you will accumulate enough of these mistakes that it will express itself as a tendency to one disease or another kind of disease, heart disease or diabetes or prostate cancer or breast cancer or AMD. And that's what they've done. They've figured out which ones of these markers predict for your risk. And you hand them on. You as a parent hand on half of your instruction book to your kids. Your partner handed over the other half of the instruction book. So if the dad has one copy of a gene that he got from his parents that has a problem marker, one that's causing a problem, and the mom also has a similar one, they're okay because they only have one copy that's causing a problem. But you have to randomly pick one of those and hand it on to your kids. If this kid picked this good copy and got this good copy, this baby's not going to have any problem. This baby's going to be like one of the parents. It got randomly a bad one from one parent, and a good one from the other parent, this kid's going to be like the parents, carrying the risk, but not really a problem because they don't have 2 copies knocked out. This baby's in trouble. Randomly, this baby is selected this copy of the gene and this copy of the gene and got 2 bad genes. This is the one that's going to have a problem. And the genetics of this are slightly different for every type of variant. And part of this is figuring out exactly how the variants have an effect and how many copies you need and the total effect of all of them interacting. Lots of work went into this. As I mentioned, 32,000 patients for the first major studies that came out showing the interactions. And very quickly, they came down to some particular genetic regions, some that were associated with complement and control of the complement protein, and others that were associated with energy metabolism and detoxifying oxidative compounds. And when you took into account lifestyle things like your blood cholesterol and your sunlight exposure, that explains more than 95% of what happens with AMD. And this is where I can't take the time to explain the details, but what I just want to show you that for each one of these single base pair variants, this is one base pair, one of those coding molecules out of 6 billion. They have quantified the actual risk, and they know it exactly across populations. And now what they're doing is quantifying across different types of populations: Caucasians, African Americans, Asians. And there's a tremendous amount of work goes into this. This is another region where there's risk associated. And if you have this single change, and if a C at this one site, and this is the number for that site, goes from a C to a G, just from one coding molecule to another, you have a difference in risk of 2.6 times. And some of the risks are big, they're like 40 times, and others are small, like 50%, a time and a half. But in total, they add up to that 80 to 90% prediction of risk. Here's another one. This is turning out to be a major one in terms of your diet. So I can't go through all of these, but it turns out there's about 30 markers now that are known to have some significant impact, and you can quantify it and predict what effect they'll have. And then you can modify that further by taking account smoking history and body weight and height, body mass index. And what you end up doing is you can talk to a person, test for their genetic markers, ask them a little history about how big they are, how fat they are, whether they smoke, and you can put a mathematical equation together and multiply the risks and come out with a total estimate of risk. And that estimate is really accurate. This was the first working version of it. We tested 5 significant, actually it was a total of 8 genetic markers for 4 different regions, and we took into account smoking history. And we came out with 5 different risk categories. This is the first part that I was involved with. And we could tell somebody with the first version of the test whether they were at below population risk or up to 75 to 80% lifetime risk. And if you got one of these answers, you had to pay attention. If you got one of these answers, basically this is telling you that you have a low lifetime risk of developing AMD. You can go sit on the beach and bake, and you can eat all the donuts you want. It's not very likely. And one of the points I want to make is this is not really different than what we do for hereditary breast cancer and colorectal cancer and a number of other diseases. This is just the same kind of approach being applied to an eye disease. And people would get a graphic representation. Here's everybody else. You got a bad result. Here's where you are. That's how much risk you have. Now, this has been refined now and improved by the addition of more markers and more statistical studies and a lot of argument and criticism and refinement. So the test is much better now. The test now looks like this. I don't provide this test. It's moved on since the original things that we did, but it gives a much more accurate prediction, much stronger one. It's based on more markers, more consideration of family history and body type, and more recently now, it has this little component in the corner that talks about what you should prescribe for vitamins and diets. And that comes out to the second part. What's the value of doing this test? And the value is that you can predict who's at risk before they develop lesions and help them prevent the lesions. Primary prevention is the best. The second part is you want to help manage the severity of lesions so people who are at high risk are going to develop the lesions or already have started to. And so what we're working on now is working with people who are at high risk and trying to ameliorate the signs of people that are affected. And there are a few things you can do. You can check their eyes more frequently. You can tell them to wear dark sunglasses. You can tell them to exercise, hit the treadmill, reduce the body weight, treat those cardiovascular signs, and you can alter the diet. And this is the second part now, where the genetic testing is turning out to be important. Not just who is at risk, but what you can do about it. All I'm trying to convince you is they know down to the portion of a molecule now why some things in your diet cause a problem and why some things can help it or make it worse. Because they know how the proteins interact. They can demonstrate it in the retinal tissue. They can show how the diet alters the impact of the complement malfunctions and your ability to handle this energy metabolism. And they know exactly why zinc might have a good impact or a bad impact. And this is some of the studies to show. You take people with AMD and you give them a type of diet, an AREDS diet, and you just separate them out by their type of genetic markers. And the severity of the lesions is different according to the type of genetic marker they have. And the difference is significant. In statistical terms, it means you could predict it and reproduce it, and it's going to happen. It's not just chance. And so they start working on this and teasing it out in more and more detail for more and more markers. And basically, marker after marker, they showed which ones had an effect, which ones didn't. And they go back to tissue culture studies, and they show why that effect happens at the protein level. And this is how they worked out exactly how one genetic region called complement factor H region has an interaction with the amount of zinc in your diet. And if you have certain types of proteins for this protein complex, zinc doesn't do you any good. And if you have other types, it helps you. And this is the part for the antioxidant side of the equation, being published and argued about in the press. And not everybody's in agreement with this. There are people who argue about the other side, and that always happens in science. Every time you publish something, there's immediately 15 people saying you're wrong, and then they have a polite argument about it for several years. I'm a geneticist. For me, this is no contest. This makes absolute sense. This is what we already do for thousands of patients a year for other disorders. They work it out to the third decimal of accuracy, the impact of the prediction and the change in outcome. And there are a lot of studies now that are being done to look at this, and they're being published and argued about, as I said. And the differences are significant. And what they do now for the treatment is they're taking the same kind of approach they do for cancer patients and for other things. They take a group of people that have the disease. They give some of them a treatment that doesn't have anything in it except sugar. They give other people a drug they think will have an impact that's good, and they give them the standard treatment, and they see which one works the best. And this separation of curves tells you that some of them have a much bigger effect than others. And the interesting thing is that for some people with certain genotypes, it turned out that doing nothing was the same as trying to modify everything. And some other groups of people did worse with some of the treatments because their genetic background actually didn't allow that treatment to have a good effect. Yeah. The question was, if you use zinc in a cream for your skin, that's one thing, but if you take it as part of your diet, will it have a different effect? And the answer is yes, probably for this disease it might.
It's not to be taken into.
It depends. Again, it would have an interaction with your risk. If you were a person at high risk, my personal belief is you would like to know what your genetic markers were like before you took a lot of supplementation with zinc. Yeah. That's my personal feeling. So this is going to have an impact. And it turns out that probably for 2/3 of patients, the genetic testing will predict a significant interaction with your dietary supplementation. And again, I have to tell you, a lot of work has gone into this, and it's still under debate. And it's going to take a while to come through and mature into recommendations that people follow. But basically, what it comes down to is more zinc in the diet causes a problem with patients that have a particular combination of what we call genotypes, genetic markers. So my feeling is you can only supplement the diet properly if you know what those genetic markers are for a given person. Otherwise, you're not taking full advantage of that ability to modify diet. And some patients are at such low or high risk that really dietary treatment will not make a big difference. Their 90% genetic is so overwhelming that the 10% diet and body and lifestyle will not have much of an impact. We see the same thing again in breast cancer. Some people have such a high hereditary risk that no matter how pure a life you live and how many times you turn down French fries, you're going to have a problem with breast cancer most likely. So this is really what I would like you to remember. This is a genetic disease. It accounts for about 80 to 90% of it. You can blame your parents, but you couldn't pick them. That's done. You can modify your risk with diet in a very beneficial way, but I think at some point it will be reasonable to do the genetic testing first to figure out how best to modify your diet and take the most advantage of that. And it's prudent to talk to your healthcare provider, whether it's an optometrist or an ophthalmologist. If you have a concern about this, that's the place to start. You need a knowledgeable interaction with somebody who knows about the genetics and the testing and the diet and all the components of your eye care. You need to talk to that kind of a person. The question was, how do you find out about your genetic markers? I don't want to push the test as a businessman. I think that the realistic thing to do is to go back to your optometrist or your ophthalmologist, the person who's looking after you for your health care, and ask about it.
There's more information on the Foundation Fighting Blindness Canada website about genetic testing. So we're going to not take any more questions, but we are going to thank Dr. Carter for generously sharing his time and expertise today.